Ishita Barua from Norway, a medical director, doctor, AI researcher, and a health tech entrepreneur. Ishita, you are at the forefront of integrating artificial intelligence into healthcare. You have a PhD in this topic from the University of Oslo. You are the CMO at Liv, the health tech startup, LIVV, and you're also on the board and member of the Wild Group, Women in Life Science Norway. Your work has earned you a prestigious award last year, the Norwegian King's Gold Medal. And you are here because you basically, we've already learned that there's a mutual relationship between FHIR and AI, mutually beneficial, but that data sharing is a prerequisite for AI, successful application of AI in healthcare. And that is exactly the title of your keynote, Sharing is Caring. A warm welcome to Dr. Ishita Barua.
Yes. So today, it won't be so technical. I will talk about the context that we live in, why we have to share data. It is actually very obvious. And to me, both as a physician, as an AI researcher, but mostly as a patient, I see it and I can feel the frustration. Why aren't we able to share our data? In Norway, there is an app for donating your organs. Okay, so you can upload that before anything happens. You can give your consent to actually giving away your organs. Data sharing, data donation, there's no app for that. Yes. So this, in 2017, was an iconic article, and front page was published in The Economist. It was telling us that data was the world's most valuable resource and that oil is no longer that. It's been 7 to 8 years, and at the time, it might have been controversial as a very bold statement at that time. It's almost an understatement today, and our data has become the product itself. Now, this is the case. Okay, sorry. So the world's most valuable data is no longer social media data, but healthcare data. And just like with oil, value isn't in the raw data. It's what you do with it. So right now, most of that data is trapped in very closed ecosystems. It's held by private companies with little transparency or interoperability. The result is a fragmented landscape where the data that could improve public health, fuel scientific research, and power clinical decision-making is siloed for commercial use. So to unlock real societal value, we need mechanisms for data sharing, which you all have been talking largely about. With proper consent, strong privacy protections, and ethical governance, imagine what we could do. Imagine if some of what that wearable data could be securely and responsibly combined with clinical data, what we could achieve. We could predict better diseases, personalized prevention, and understand population health in real time. So data sharing is the pipeline that turns personal insights into a collective breakthrough. Without it, we're just actually drilling in isolation. Now, have a look at this picture. So this image shows a powerful glimpse of what AI can do in healthcare, transforming a simple chest X-ray into a comprehensive health assessment, flagging a lot of things, possible type 2 diabetes, calculating coronary calcium score, confirming normal heart function, and estimating a 10-year cardiovascular risk of 14%, even suggesting treatment considerations. So it illustrates how AI can extract clinically relevant insights far beyond what the human eye really can see, provided that we have access to large-scale, high-quality clinical data. But while this opens up exciting possibilities for early detection and more personalized care, it also raises a critical ethical question. So whenever the patient comes in to do an X-ray, do they really want to know all this? Some may find this information empowering, others will think it's overwhelming. So the key is that people should be given the choice with transparency, context, and support, so that AI becomes a tool for agency and not anxiety. We should ask our patients, How much do you want to know? Right now, even the doctors are struggling to convey all of the data, all the variables that we actually can catch with just an X-ray. Now, there are other people, especially on social media, who are asking, what are we doing with AI? So some, very poignantly, they say, okay, we should use it for breast cancer research, for instance, being able to catch cancer 5 years before it happens. Others are saying, oh, well, I was supposed to make poems and write stuff, but now AI is doing that while I still do the dishes. So we really have to have a conversation about what is the purpose of AI use. How can it benefit humanity? Well, last year, the Nobel Committee, they found that this was a very good use of AI. Now, these are the researchers that the Nobel Committee found to be the winners in physics and in chemistry. And it has given us a glimpse of the future of science. So AI was central to the discoveries honored by both awards. Now, there is a close connection between the AI-based advances honored in physics and chemistry. Hinton helped develop an approach used by DeepMind to make its breakthrough in predicting the shapes of proteins. And we're certain to see many more Nobel medals handed to researchers who will make use of these AI tools. Now, there is a challenge that we need to address in healthcare, and it's called the 60-30-10 challenge. And healthcare represents a paradox. So while change is happening everywhere, performance has flatlined. 60% of care, on average, is in line with evidence or consensus-based guidelines. That is not enough, only 60%. Then 30% is in some form of waste or of low value, and 10% is directly harm. So the 60-30-10 challenge has persisted for 3 decades. We need to address this. How can we leverage AI to actually help us with this? And even with technology providing increasing volumes of data and more sophisticated analytical tools, progress continues to be very slow, painfully slow. So remember this when you build AI tools. 60-30-10 challenge in healthcare, it still persists. Now, I'm going to get a little personal here. So 2 or 3 years ago, I joined a group of clinical AI experts on a trip outside of Norway. We were visiting a lot of countries that had started to implement AI tools in their clinical systems, so in healthcare as in hospitals. And they had successfully implemented a range of AI tools in their clinical workflows. And we also met with several startups that were at the forefront of developing cutting-edge AI tools for healthcare. One company had devised an AI tool for screening age-related eye diseases with an accuracy exceeding 90%. That's what they told me. So during a demo, they needed a volunteer. And glancing around the room, I realized, okay, I was probably one of the youngest. And some of these eye diseases, they weren't manifesting until late 60s. And since I was in my 60s, I was thinking, okay, I can volunteer. It's probably going to be nothing. I was screened for 3 types of age-related eye diseases, and 2 tests came back green. I was clear. But to my surprise, the 3rd glowed red, and I had tested positive for glaucoma. I was stunned and immediately asked, do I have glaucoma? To the people who were at this stand or this booth, the developers behind this AI tool. And the startup staff, they had no answers for me, and none of them were healthcare professionals. They simply said, we don't know, next. They just moved on. They did not know that I was a doctor, so they could have thought, like, well, she probably knows something, so we don't have to explain. They didn't know anything. So that was very strange. Yeah. Furthermore, they disclosed my diagnosis in front of the whole room, to which I had not explicitly consented. So that was failure number 1. And this experience, it left me with a diagnosis, but no real patient care, and no experience of that, no privacy. And I returned home from that trip, and I had a flurry of questions and a lot of worries. So as a trained physician, my first instinct was to consider, could this be a false positive result? Meaning that the AI screening tool, it incorrectly had identified a condition that really wasn't present. But given the AI tool's claimed accuracy of 90%, I couldn't dismiss the possibility of the result being correct either, a true positive. So as soon as I returned home, I visited an ophthalmologist, and she quickly assured me that my eyes were fine. The thing is, I didn't want to bias her, so I didn't tell her that the AI tool had given me a diagnosis, okay? So she didn't know. I just told her, I think something is wrong with my eyes. Can you please have a regular checkup? And then she looked at my eyes. They were fine. And then I mentioned the AI results. And then she had a second look. This is an image of my retinal scans. Pretty normal. And then she explained that, okay, I had a second look, and while you show no signs of eye disease, you do have a condition that is a normal condition, and it's called myelinated retinal nerve fibers on one eye. You can see it on the left picture, so there's a flash of light. And it's normal, she said. It won't harm you, doesn't cause any pain, no nothing. You will still have your sight intact. It's just a visualized white area, only visible in that picture and not on the left picture. So myelinated retinal nerve fibers can be hard to differentiate from glaucoma in images. And it seemed likely that the AI model hadn't been adequately trained to distinguish maybe this condition from glaucoma, the normal condition from glaucoma. So I asked her, okay, so could it be that the AI tool is mistaken? Oh yeah, that could be. How common is this normal condition? And then she said, less than 1% of the global population has this. So imagine, okay, so now I knew, okay, this is the problem. What do I do with it? Can I have my pictures, please? How will I send it to you? Maybe you can have a CD? That's not really going to cut it. So what I did was that this picture is actually a screenshot of her computer. This was as good as it gets. You see my point? So my wish was to go back to the startup company and donate my data so that they could improve their AI tool. That wasn't a possibility. And also, my data belonged in Norway. This was another country, blah, blah, blah. A lot of bottlenecks there. Now, this experience illuminated the challenges we face with AI in healthcare, the need for comprehensive training on diverse conditions, the importance of patient data access and privacy, and the fundamental requirement of requiring AI insights with compassionate patient care. It also casts a spotlight on broader issues such as health disparities. This was me, but imagine, okay, so I already know that I am a minority. I know that I have brown skin. What I didn't know was that I was a double minority. My eyes were also making me a minority. This means, in terms of genetics and things that we don't really see, that aren't manifested, everybody could be a minority. And their data could be lacking, and could be that we are producing AI tools on imbalanced data sets. And we are. So I was discriminated by an AI tool due to the lack of diversity in the data sets. I was basically, like I said, a double minority. And the lack of data ownership is also a problem. So I was denied my right to access my own health data, and thus I could not provide retinal images for retraining that AI model. These are not good enough quality for these images. Now, there are other examples of this also. So in a widely reported study published in Science in 2019, a group of researchers at the University of California, they revealed that an algorithm used by US hospitals to flag high-risk patients for enhanced medical attention exhibited significant racial bias. So Black patients were less likely to be flagged for additional care than white patients, even when they were equally sick. So technically, there was nothing wrong with the algorithm, and its creators never intended for it to discriminate anyone. In fact, they designed the algorithm to be race blind. Then what caused it to be biased? The problem with the algorithm was that it predicted future healthcare costs rather than future illness to identify high-risk patients in need of extra care. So because Black patients in the US on average tend to have more limited access to high-quality healthcare, they typically incur lower cost than white patients with the same conditions. Now, relying on healthcare costs as a proxy for health risk and healthcare needs, therefore put Black patients at a considerable disadvantage. Now, when the researchers ran a simulation with clinical data instead, the percentage of people referred for additional medical care who were Black patients, that increased from 18 to almost 50%. So this study, it highlights how deep-rooted disparities in healthcare system can unintentionally be reinforced by AI algorithms. And with careful design, AI has the promise to create a more fair future for all. But the thing is, like the New York Times article says on your right, changing algorithms is easier than changing people. So software on computers can be updated. The wetware in our brains has so far proven much less pliable. So as an AI researcher, we know that some of the answers to how to correct this lies here. So there are bias in every corner here. So you have, when you do the data collection, data processing, algorithm development, algorithm deployment, really at every instance. The problem is also something that you do not see here, and that is the clinical validation. It also needs to be done. So just being able to analytically validate is not enough. Outside of this, you also need to test in a clinical environment. So much work remains, but I believe with the appropriate diversity in people, data, and validation, supported by strong quality management systems and monitoring processes, we can successfully mitigate some of the risks of bias in AI. So in the era of precision medicine, we need to really address this. Like I said in the beginning, in Norway, we actually have this organ donating app that you can download. But what we really need is something for data donation. So what we really need to do is how to get access to both sensor data, but also real clinical healthcare data. What we are lacking is the last one. And AI needs patient-owned data to reach its full potential. So one, higher quality and diverse data so that patients directly can contribute with more representative data sets. Then you also have to have like an alignment with patient goals. So AI models are only as good as the objectives that they are optimized for. Then that will drive the innovation. Now what we're seeing is, this is also another cover from The Economist, they're pointing out there's a rise of the superhuman. That may be. There are a lot of variables that we can look into, and we can, with machine learning, deep learning, find patterns that are meaningful, clinically meaningful. However, if you remember the picture that I showed earlier from The Economist and my version of it, with the oil rigs replaced with Garmin and wearable companies, that picture powerfully illustrates how major tech companies like Apple, Amazon, they become the new oil rigs. And these platforms have built private empires on information about our heart rate, sleep, stress levels, activity, and daily routines. And many more are coming. But here's the catch. While this data is abundant, it's also narrow. So it reflects wellness, it doesn't really reflect illness. So clinical data, like imaging, lab results, diagnoses, medications, and treatment outcomes, remains locked away in fragmented, siloed health systems. So this is like trying to build the future of healthcare with only half the blueprint. If we want AI to truly transform medicine, we really need to access richer, more representative data sets, not just from healthy and wealthy people wearing watches, but from real patients in clinical settings. Give them the tools to own their own data so that they can donate the data directly to researchers or even companies doing research. And that includes also cancer registries, electronic health records, genomics, longitudinal patient outcomes. Those are the things that we're looking for. Otherwise, we risk developing tools that just optimize for the already healthy and leave out the sick and leave them behind. So clinical data is the missing oil, and we're not fueling innovation, we're just circling the platform. So I would like to end with a note. So in medicine, the Hippocratic oath is first, do no harm. And Mark Zuckerberg, he has this other mantra, move fast and break things. The thing is, that's really not useful in healthcare, breaking things. So we should actually just merge them. Move fast, but do no harm. Thank you.
Thank you so much, Ishita, for this wonderful presentation. Before we move, we have a few minutes, I guess, for questions. But first, I have a question for the room. The app where you can donate your data. Who of you would actually donate your health data to if there were an app such as described by Ishita? Well, it's quite a few people. And maybe a follow-up question that you showed us the scan, and what is there to know about yourself? Who of you would want to know everything there is to know about your health? Who? Who would not? It's a bit of a dilemma, huh? Okay, let's move on to questions. We have time for a few questions. Anyone? Mikael.
Thank you. Of course, could have asked how many of us have already donated our data. So there's, for instance, openhumans.org, a platform where you can upload your data if you first get it. So the problem is first to get your data in a format that you could actually then transform.
Thank you for this comment. Anyone? No? No questions here? Well, well, you're in this field, right? So.
Yes, and while I'm waiting for the others to get their thoughts together, I'm sure there will be other questions. Regarding your experience with the retina scan.
Yep.
When you now look back at it, how do you feel? Was it a terrible experience, you'd never want to go through that again, or was it still something positive and you learned? How do you feel about that?
I think it was a learning experience. I actually value that experience a lot because after having experienced that, I got into work with my own startup, like donating data. So I just recognized that there was a problem, which I didn't face as a physician. I faced it as a patient, right? So as a physician, I didn't really see why everybody else was going to share their data. As long as I got the patient data, then I was fine. But as a patient, I realized, holy shit, this is not going to hold up. So that experience made me into an entrepreneur. I don't think I would have been going into startup before and prior to that experience. And also, even if it was a concern as a physician that you're not getting hold of data from other doctors, it's just made it so much more clear to me that this is where we need to really empower our patients. We're not going to get recruited the data sets or the balance of data sets if we're not being handed that from the patients directly. So with FHIR and all the technical aspects of it, that's fine, but we just need to address this is important and we need to decide that this is going to be an opportunity for the patients.
Perfect. Yeah. I'll come up. Oh, good.
Hi, my name is Melle. I'm also a doctor, but here in the Netherlands. And in the Netherlands, we tend to have a bit of a reluctant view towards screening in general, I think. And this is probably very nicely illustrated by the story that you told, right? Because you got what was eventually a false positive, but your screening triggered follow-up. Now, in this case, that was fairly benign. Going to an eye doctor is fine. But if you had to undergo a colonoscopy, you might have gotten some complications from that. What are your views on that in general? Do you think the benefits eventually will outweigh the risks?
It's so funny that you ask because I am actually an endoscopist. I was doing colonoscopies prior to this. So in colonoscopies, you have a miss rate of 20%, okay? So in 20% of the colonoscopies, you will not discover the polyps, the pre-lesions that could be cancerous. So that's why you think you would need AI to be able to help the doctors support them in finding these polyps. They are difficult to find. What we're seeing is that we have, in my own research, we were actually able to discover 50% more polyps. However, rarely were the polyps that were actually going into, actually being cancerous in the end. That would also take 10 to 15 years time anyway. So we're over-diagnosing and over-treating people. So it really depends on the AI tool and the organ system and the disease. But for colonoscopies, the example that you took, it wasn't really beneficial. We were just overdiagnosing. And we spent more time removing polyps that never needed to be removed and creating a problem. So it really depends. That is not the case with breast cancer, though. With breast cancer, you're seeing a lot of good AI tools that are actually in Sweden. They have a very large study, and they saw that they were able to detect 20% of the breast cancer, like actual cancers, before, like in 5 years ahead of time. This was a big RCT. So for breast cancer, that worked fine. It was an overdiagnosis. For colon cancer, it was overdiagnosis. So it really depends, and one of the things that we're lacking is robust validation. We need RCTs that proves, did the AI tool do what it promised? And if it did, how much of an overdiagnosis was made? Like, there are a lot of costs and a lot of resources going into that. And with the constrictions that we have in healthcare, that is really what we need to avoid, overtreating people. So my answer to you is that it really depends on the AI tool and the organ system. Like it could look different from breast cancer to colon cancer. So for colon cancer, we couldn't really prove a benefit. We couldn't prove that using AI was giving us a benefit other than overdiagnosis. For breast cancer, it was different.
Okay, thank you very much for elaborating on that valuable question. And with this, I would like to thank you, Ishita. Thank you very much for being here with us. Thank you, everyone.